Well, we are coming down to our last presentation, and unfortunately, Dr. Alan Zhang, who is our next presenter, lost his voice this morning. He was all ready to go. He's not feeling too bad. This actual lecture was specially selected because it was the most popular lecture from our physical therapy and athletic trainer conference that we hold in the summertime. Fortunately, we did record it, and he is going to come after the lecture itself to do the Q&A. So while he can't give it himself, we're going to use his recording, and then he's going to join us for question and answer right after. So let me share screen and let you hear about when does your patient need advanced imaging. To introduce Dr. Zhang, though, he is one of our faculty orthopedic surgeons. He did his medical school training down in UCLA, as well as he did his fellowship here with us at UCSF and has stayed on as faculty. And he's a prolific researcher. I think if I heard this stat right, I think he published 150 papers or something like this with all the fellows and residents that he works with in 1 year. And so I'm going to let him tell you about when he orders advanced imaging.
The topic of this talk is, when does your patient need advanced imaging? Okay, so here, this is an area where all of us are getting, there's been some changes in the regulation of this area, and there's also changes in patient perception of imaging. So I think this is a good topic for us to cover across the spectrum for all of our providers, regardless of what you're specializing in. Okay, so the outline for this talk for advanced imaging is that we're going to talk about the different modalities for imaging and why we use each one, and then how to interpret the imaging findings, what's normal, what's not, and then some of the obstacles to ordering imaging, and then when your patient should actually be getting imaging. So why do we want to image patients? So if the patient has a new injury, especially a traumatic injury, this is always important. So it allows us to find things like fractures or traumatic soft tissue injuries, chronic problems that aren't getting better, such as this is a picture of a wrist that's having arthritis. Those also benefit from imaging. And then also for within the musculoskeletal realm, we also use imaging to rule out these very, very rare soft tissue tumors. So sometimes the patient can be otherwise healthy, and then all of a sudden they have shoulder pain. And sometimes we definitely need to image them to make sure there's not a rare zebra, so to speak, in our midst. And then lastly, why do we image? Because patients want it. Okay, so I'm sure you guys have all heard it. Body part hurts, I need an MRI of everything. I need the most advanced imaging you can get to look at everything. So we got to do what our patients want. Okay, just kidding about that part, but we'll talk a little bit about that later. Now, imaging studies, they help us in diagnosing injuries, also help us determine the significance, and also treatment plans. So we got imaging here ranging from x-rays to MRI, and then also arthroscopy surgery, which in a way can be diagnostic. So that's like kind of the ultimate imaging modality if we actually have to figure it out during surgery. And what are these basic modalities? So the first, we have our radiographs, and then ultrasound, CT scan, bone scan, and then MRI or MR arthrogram. So radiographs, imaging is obtained by projecting an X-ray onto a detector, and then essentially it'll pick up mostly pathology with the bone. You won't get much soft tissue stuff that shows up with imaging. And then the brightness is a function of the radio density and the thickness of the object. Okay, so denser objects will have brighter imaging. Okay, and then on x-rays. So it's a good first line evaluation, and usually you need multiple views. So like for a shoulder, you can't tell everything just from one x-ray. So usually we'll take at least two to look at it from different views, more than likely three. Some patients are very resistant to x-rays because they're afraid of the radiation. But for spot dosage of x-rays, the radiation burn is very low. Okay, what are we looking for with radiographs? Fractures, whether they're displaced, comminuted, impacted, and also arthritis. So these are all very, very easy to tell. And the X-ray is gold standard for diagnosing this. You don't need an MRI to diagnose arthritis. Okay, and then also abnormal bony morphology. So this is a patient with a severe hip impingement, or FAI, on both his hips. And you can just see the shape of his hips are very normal with these large bone spurs here, and then also bone spurs on the acetabular side. So X-rays help us define a lot of things even better than the other advanced imaging studies sometimes. Okay. And what are things that are red flags on X-rays? So definitely anytime you see a displaced fracture, it always needs immediate attention. Non-displaced fractures, usually we can treat those conservatively and may not need as much urgent attention. Depends on where that fracture is and how stable it is. And then stress fractures, which we can't really rule out on X-rays. So this is something that needs secondary evaluation and further imaging. So if the X-rays turn up pretty normal, but they have symptoms of a stress fracture, which we'll also discuss later, that's when one of the things we use for advanced imaging. Now, another relatively benign imaging modality is ultrasound. So this is where you're using high frequency sound waves to produce an image on your monitor. And it can be helpful to evaluate fluid areas such as cysts or bursitis. And then, so you can use this for like Baker's cysts, wrist cysts, iliopsoas, tendinitis, bursitis, shoulder bursitis as well, of course. You can also use ultrasound to detect certain tendon tears. Most commonly used ones would be for rotator cuff tears. So if a patient for some reason can't get an MRI, then one of the things you could do to look at their shoulder is using an ultrasound for that. And this is also a pretty easy way of looking at your rotator cuff repair healing. So post-surgery, sometimes the MRIs have too much signal. So using an ultrasound to diagnose rotator cuff healing is a very good option as well. And then lastly, if there's any potential worries about blood flow, such as like a post-surgery blood clot or DVT, you definitely need ultrasound at diagnosis. That's the right modality. So if you guys are seeing patients who have had lower extremity surgeries and there's calf swelling and pain, those patients need to go to the ER to get an ultrasound by our ER doctors to look for a blood clot. All right. So ultrasounds, they're non-invasive and they're dynamic. So you can actually move it back and forth and also flex the foot or knee back and forth to see how a tendon looks dynamically across the ultrasound. So instead of just having the tendon sit in one place like we do for like MRIs, ultrasound, you can actually see what that tendon looks like dynamically. Disadvantages are that if your tech is not very experienced using ultrasound or your reader is not very experienced, it could be a little inaccurate. It does take quite a bit of training to be able to use the ultrasound and read it proficiently, and it can't get to deep tissues that well. So sometimes you can get, for the hip, you can get to the iliopsoas, but it doesn't really do great with deep tissues. Okay. And then you also cannot image tissue within the bone. So if there's anything you're looking for underneath, like a bone that's protected by bone, you can't really see deep down in there for some of those tendon attachments. Now, the ultrasound can also be used for targeted therapy. So we like to use ultrasound for guided injections. So you can use this for injections of the glenohumeral joint, whether you want to do like cortisone or some kind of viscous augmentation. You can also use ultrasound to treat calcific tendinitis. And then definitely we use a lot of ultrasound for intra-articular hip injections, because it's just, the hip is such a deep joint that you can use the ultrasound to find where the joint is and inject the needle pretty well. Okay. Another modality is your CT scan. So this is like a tomographic evaluation of the region of interest, and you can also use it to recreate a 3D bony anatomy. So this is good for the shoulder if you have like shoulder instability. So we can use this to look for glenoid and humeral bone loss. And for the hip, you can also look at the version of the socket and the femur to see which direction it's rotated. And then also like complex reconstructions, whether it's shoulder or hip or knee, you can use a CT scan to plan your approach. And then also post-traumatic bony injuries, like where the fractures aren't well healed, or if there's a malunion, you can use a CT scan to see exactly what areas are weak or not fully healed. Now, the CT scan does have advantages in terms of 3D shape and measuring bone loss, and it's actually better than the MRI for some of these, and especially fractures and fracture healing. The CT scan is much more effective than an MRI for evaluating this. Okay, the disadvantages of the CT scan is that when you have metal, it can just basically ruin your image, where there's a lot of artifact from like the metal reflecting the X-ray particles. So there's quite a bit of artifact from that. Whereas MRIs, there's certain sequences where you can try to minimize the metal artifact a little bit better than the CT scan. CT scan is like a smaller tube. So if you have a large patient, they won't be able to get it. And then also this is a lot of radiation. So this is one of the reasons in the Bay Area, we probably don't get that many CT scans, because if a patient's afraid of getting an X-ray, yeah, there's no way they're going to get a CAT scan for you. All right, when it's like 229 X-rays for a CT scan. And definitely if somebody's pregnant, you don't want to put them through the scanner. Even like young adolescent female patients, I worry about putting them in the CT. So I don't usually, when I see patients with like hip pain, I don't do a CT scan for them, but I've seen some other patients come in with like CT pelvis when they're like a teenage female patient, which I would be a little bit worried about radiation for those. Unless it's absolutely needed, I try to stay away from this. And then, so for example, here in the shoulder, you've got X-rays looking at instability, and you can see that maybe there's something wrong with the front of the glenoid here. But then when you get a CT scan, and then you can do a 3D reconstruction of it. So they pretty much automatically, most of the time, they can just do this from the normal CT. You're not doing more radiation, and they can just recreate this. And then you can see where that bone is essentially broken off and also deficient in the anterior glenoid. For wrist fractures, you also can get CT scans looking at the hook of the hamate. So some of these you won't be able to see on X-ray at all. And then a CT arthrogram, this is where you inject contrast into the joint, and then you get a CT scan. And this allows you to check for rotator cuff tears when the patient cannot get an MRI. So such as when they have a pacemaker or loose hardware, like usually it's like a bullet fragment somewhere, then they can't get an MRI. So then you can do a CT arthrogram, because that arthrogram will basically outline the rotator cuff. And if there's a tear, you'll see that contrast leaking through on the CT scan. Okay, so intra-articular contrast, this is iodinated injection into the shoulder or the knee, can help diagnose rotator cuff tears, labral tears in the knee. If they can't get an MRI, this is how you can do an ACL tear. And then also a meniscus tear, you can see those with the CT arthrogram. Nuclear imaging, so these use radioisotopic labeled drugs, where you inject it through the IV, and then it basically goes to different areas of the body and lights up based on what you're tagging. So most of the time you're tagging like some product of glucose, and you're just seeing where that goes, because like the areas where the joint or the muscle is like most active will absorb that the quickest. So images are produced in that way. That's what scintigraphy means, and scintigraphy. And then technetium bone scans, and then also the glucose FDG as a form of glucose in PET scans. And then those measure the glycolic rates. And then and you can also use it a lot for tumor cells and oncology, because tumor cells will eat up a lot more biomaterials than your normal cells. So this is where you can do a nuclear scan, and different areas that will light up. That's where you can look for metastases, essentially. Bone scan really to rule out tumors, sometimes infection. You can tag the white blood cells. And then sometimes you can use it to evaluate joints with arthritis, as well as stress fractures and non-unions, because those areas will kind of light up differently on this. But this is very seldom used for like our routine musculoskeletal patients. It's seldom we say, hey, we got to get you a bone scan for this. All right, and then advantages are that it follows the metabolic activity. So especially if there's like an oncology patient, this is really good for that. And then you can use it for post-op if you want to try to see if there's a diagnosis of an infection sometimes as well. Of course, you can see the images that it gives you is essentially just areas of different color or darker versus brighter signal. So it's really not as good in terms of high resolution and it's limited sensitivity because due to different things, some cells may take up things in a different way. Okay. All right. All right. And then next one. So the most common imaging modality we use is MRI for advanced imaging. So this is currently the gold standard for soft tissue injuries. So this would be like rotator cuff tears, labral tears, ACL or other ligament tears, as well as cartilage injuries. So they use a magnetic field to generate nuclear spin in the hydrogen atoms. And then as the hydrogen atoms relax, the time is recorded, and then it can be translated into different imaging images. Okay, so here you can use an MRI to look at the quality of the muscle. You can use it to see if there's any tendon tear. It can pick up fluid very, very well. And then labral pathology, cartilage, fluid in any of the bones or joints, as well as you can see tumors and stress fractures very well with the MRI. So the MRI scanner. So I think this is an important pearl because based on what type of MRI scanner the patient gets, it tells you, it shows you how good their pictures are. So if your patient goes to a 0.3 Tesla, so the Tesla is a measure of how strong the MRI scanner is. So if it's a 0.3 Tesla scanner, which is like the first MRIs to come on the market way back in the 90s, and it's still being used in Bay Area offices. There's still a lot of practices that have their own MRI scanners that are, you know, older scanners, and their patients will get low 0.3 or 0.5 Tesla scanners. And this is what it looks like essentially when it comes out. So you can barely see anything. It's very, very hard to tell like the more subtle injuries like meniscus tears. If you have like a big ligament tear like an ACL, that's probably fine for that, but it definitely has its limitations. Then you go up to the second generation or the 1.5 Tesla MRIs, which are pretty good. So it's the top and bottom on the right. And then the third generation 3 Tesla MRIs, this is kind of what the major medical centers all have. So this really shows all the quality and high definition. When you're looking at it, various sequences will definitely show a lot more than the 1.5, but the 1.5 is much better than these low quality ones, but 3 Tesla is definitely the best. So the ones around the Bay Area that have 3 Tesla MRI scanners are UCSF, RadNet, SimonMed, and also the Sutter scanners. So, and of course, Kaiser has one too, if your patient has Kaiser. So I would typically, when I refer for MRIs, refer to one of these scanners, because if you get a low quality one, it really doesn't help you very much, okay? And the MRI scanner, it can definitely worsen claustrophobia if the patient has that. There's loud noise and it takes 30 minutes to an hour for them to do. And you're, for the most part, you're like inside of this tube for that whole time. So it's something to advise your patients about in terms of the scan itself. You can also get an MR arthrogram where you inject gadolinium inside of the joint, and this can be picked up very well on your MRI. So it helps to distend the joint. It also enables further evaluation of like small tears of the labrum in the shoulder or the hip. Also, really small rotator cuff tears and cartilage injuries can be diagnosed using MR arthrograms. Now that we have 3 Tesla MRI, the 3T MRIs, multiple studies have shown, especially for larger joints like the hip or the shoulder, 3T MRI is just as accurate as an MR arthrogram, okay? Because when you actually need to do an MR arthrogram, you can't do it on a 3T MRI. You have to basically decrease the Teslas or else there's too much signal. So when you do an MR arthrogram, it's essentially a 1.5 T MRI with the contrast versus a 3 Tesla MRI without contrast. So here in the hip, you can see a 3 Tesla MRI, you can see that labral tear just fine without any contrast in it. So that's the labrum, that little triangle, and it's separated from the bone. And you can see where the 3 Tesla MRI picks up the native fluid there very well in between the labrum and the bone. And then now this would be an MR arthrogram for labral tear. You see there's just a lot more bright fluid in there because we've injected all this contrast, and it can kind of seep in and define that labral tear even further. But it's really more useful for like smaller labral tears like this, where you may not see it on a normal MRI, but then the fluid goes into the area of the tear, these little bubbles, and then you can tell for sure that it's torn there. But again, even with hips, like I seldom get arthrograms nowadays. Most of the time, I just do a regular 3 Tesla MRI. And then there's that's MR arthrogram, but you can also get an MRI with IV contrast. So this is where you're injecting dye into the arm, and then you're seeing where that contrast, as it goes into the joint, you're trying to use that to look at vascularity. So this would be for like tumors, and then sometimes you can use it for like post-surgical changes, like such as to determine scar tissue, because the scar tissue will have less blood flow typically. And then and then also with the contrast, there's kidney insufficiency and complications. Okay, all right, and then interpretation of your MRI findings. So when we go to this next phase, okay, when you get these MRIs, you're going to get a lot of different things picked up. So what's actually normal and what's something that we worry about for asymptomatic patients? When you're looking at the shoulder, probably the most common thing what we're going to pick up is like rotator cuff pathology. So if you're looking for at patients over age 60, like half of them have a rotator cuff tear that do not have any symptoms, okay? And within that 54%, half of those are full thickness tears, the other half partial thickness tear. So if you're over age 60, a patient doesn't have any pain, but you get them let's say they have like pain in their left shoulder, and then you get them MRI of their left shoulder and their right shoulder, it's probably a 50-50 chance at least that the right shoulder also shows some type of rotator cuff pathology, even though they don't have any symptoms. Okay, and then for the younger age group, it's a lot less common, especially full thickness tears. If you're seeing a full thickness tear in patients under 50, that's usually pathologic. Okay, but then over age 60, you can definitely have a full thickness tear without much. So be careful with the interpretations. You really want to treat the patient clinically based on their symptoms and not just what the MRI shows, because there's plenty of incidental findings, right? So rotator cuff, which we just talked about, full thickness versus older patients that are asymptomatic. Labral tears, so anterior labral tears, if you find this on the MRI, that's usually going to be associated with dislocations. That's a part of the body that you usually don't get asymptomatic tearing from. So the anterior labrum is off. It's quite an important stabilizer for the shoulder. So if that labrum is off, then it's very likely that the humeral head is going to be unstable. The superior labral tear, however, is very common in overhead athletes. So a lot of these patients under age 45 may have superior labral tear, and they may have some pain with it, but a good percentage of them can do well with conservative treatments. I would say over 70% of patients with slap tears can improve a conservative treatment. So it's not something just because we see it that they need to have surgery for. On the other hand, degenerative labral tears in older patients, especially patients over age 50, that's going to be an incidental finding, because when you have a little bit of degeneration and chronic wear and tear, it's very easy to have like a fraying or just a little bit of kind of maceration of the labrum, especially when you're an older patient. So that's more of a normal finding as well. And also the patient has weakness, and you just see a degenerative labral tear, that's not going to be responsible for it. So labrums do not correlate with weakness for patients. Okay, and then the AC joint. So when you get an MRI of the shoulder, like almost every AC joint looks terrible. So just because there's fluid there, even if there's a little bit of arthritis, it's a very frequently overread diagnosis of AC arthritis when you get an MRI at the shoulder. So if they don't have like a prominent spur, if it's not painful when you palpate the AC joint, we definitely will just leave these alone. In the hip, so this is something I see a lot of patients for. There's this very, very high prevalence of asymptomatic labral tears. So they did a study in Colorado where they imaged 45 asymptomatic patients. Average age was under age 40. Labral tears were identified in 69% of those patients on MRI. Okay, so these are all asymptomatic patients. So for patients who are over age 30, over age 40, over age 35 or 40 with isolated labral tear on MRI without any like FAI or bony pathology, it can very well be just an incidental finding and not necessarily a pain generator. Okay, However, the patient has FAI. Probably over 95% of them have been shown to have either cartilage or labral injuries. So if there's hip impingement in terms of the bony morphology, then it is very likely that the labral tear can be that the labrum can be torn and injured and contributes to the pain syndrome and pathology. Okay. Meniscus tears. So there's also degenerative meniscus tears are very common also in patients over age 50. So most of these are asymptomatic tears. And there's been very good randomized controlled studies showing that degenerative meniscus tears should not be treated surgically, especially in the setting of arthritis. Okay, there's been no improvement compared to sham surgery. So what I consider degenerative meniscus tears would be like horizontal cleavage tears or complex tears. So in this MRI here, you see this kind of white line right between the two. So that shows like a horizontal cleavage tear. Most of these can be treated asymptomatically. And then in this case here, the ones that usually cause a lot of pain are flap tears that are displaced. So that's where, let's say this bottom tear got displaced and curled under. So that's what this is showing. You can see this posterior horn piece is coming over the plateau, going down the back of the tibial plateau. So this can definitely cause a lot of pain because there's now a mass effect of this pushing on the capsule behind it. But here, when the two of them are just lying on top of each other, when you actually walk, you're actually compressing that tear and stabilizing it. So these type of non-displaced tears we're usually a lot more conservative about surgically. Now, in terms of rotator cuff tears, okay, so you want to think about interpreting the reports. So there's different types of adjectives. I mean, not just rotator cuff tears, but different types of tears. The radiologist will describe fraying versus partial tearing versus full thickness tear or versus retracted tear. And then also cartilage, fissuring, flaps, unstable cartilage versus full thickness cartilage loss, and then also tendon degenerations versus tendinosis versus tear. So these are all kind of adjectives that they describe, but they all kind of can mean similar things. But really, especially when they say clinical correlation is recommended, this is where we really want to look at the whole picture. So here you've got this report from a 55-year-old who's had posterior shoulder pain for a year without trauma, and they've got this full report impression irregularity of the anterior superiors and superior labrum compatible with degenerative changes, blunting of the anterior labrum, tendinosis. So when you get these really kind of verbose reads, essentially what it's telling you is it's a 55-year-old male with no trauma and age-appropriate changes. So I think not just what we see from the radiology reports, but we want to paint the full picture and interpret a little bit. Now, on the other hand, here we got a full 51-year-old who fell on the shoulder with the acute trauma. And then here we see full thickness tear with the anterior footprint of the supraspinatus and also tendinosis. So here we've got an acute injury with the full thickness tear, 51-year-old, relatively young patient. This is a patient that's going to need some likely surgical treatment for this. Okay. And then now, even though a lot of patients want MRIs, there are definitely a lot of new obstacles put in place for us ordering them. So every week I get patients emailing me and say, hey, I need an MRI of this or that, or you saw me for my right knee, I also need an MRI for my left knee. And the problem is I can't just put it in the computer and say, okay, MRI for this person, just because, you know, I went through years of medical school or whatever and whatnot. The insurances nowadays are capping a lot of these with pre-authorization processes. So what they're looking for, so in order for the insurance to approve an MRI order, the patient for a lot of injuries will have to have shown 6 weeks of failure of conservative treatment, which includes physical therapy, NSAIDs, and activity modification. If they haven't done that, most of the time they're not going to allow for an MRI. Now, if they've had an acute traumatic event, that's a different thing. If you're ruling out for like an acute rotator cuff trauma, then usually that they'll be able to read the note and allow that. But for subacute injuries or like chronic pain, if they have, even if they have pain for 10 years, if they haven't tried PT for at least 6 weeks within the last 3 to 6 months is what they usually say, then they're not going to allow you to do that. Then we have to send the patient back for more conservative treatment. And then also another hurdle is that most of the time they have to have x-rays done first before they get an MRI. So if the patient hasn't had an x-ray, you really can't order an MRI until you look at the x-rays. And also physical exam documenting positive provocative maneuvers. So a lot of times when the primary care doctors see these patients, they may or may not do all the orthopedic specific exams or document them, and then the insurance will deny the MRI based on that. So a lot of times patients are coming into the orthopedic specialist not because they're here because they need a surgical consultation. It's because they need you to work up their thing and do an exam on them and send them to conservative treatment just so they can get imaging on it. So that definitely slows down the process, but it is what insurances are like these days. And if you think getting an MRI is hard, it's just as hard for getting surgeries approved, even for very necessary surgeries nowadays. Okay, but so in terms of injuries with imaging hurdles, let me just make sure. Yeah, for when, so now we're talking about when you want to refer for imaging. So the ones that are going to be hard to get through with insurance, these are going to be the ones that are that they want conservative treatment to be performed first. So this would be like meniscus tears, unless it's like bucket handle tear, the patient has like a locked knee. Patellar instability, because that's usually more chronic. Slap tears, because PT works pretty well for that. So they usually want patients to try that first. Non-acute cuff tears, so chronic shoulder pain in the older patient. Bursitis, hip FAI, and labral tears, these all need conservative treatment first before they let us do anything. Trochanteric pathology, trochanteric pain as well. Acute injuries that can kind of bypass that, where we just need the images. So the best way to do that is getting them to see an orthopedic surgeon urgently, because the ortho office, sometimes we could do like peer-to-peers if we need to like discuss what we're worried about and why why it necessitates an urgent MRI. But some of these injuries like ACL tears, quad tendon ruptures, fractures, some fractures that need advanced imaging, bucket handle meniscus tears, like acute trauma for the shoulder, acute falls, shoulder dislocations in patients over age 50, because almost over 40% of those patients will get a rotator cuff tear if they're dislocating their shoulder over age 50. Okay, so for instance, here, there's a 55-year-old male who fell off a bike with pain and weakness for 7 days. We're not going to put them in PT. This patient had like an acute traumatic rotator cuff tear. So we needed to get that MRI ASAP because he needs an urgent procedure. Other things like in the hips, you could get like a proximal hamstring tear where there's a lot of bruising. You feel that pop in the back. That definitely needs an urgent MRI. Stress fractures also need urgent MRIs anytime we're ruling that out, because a stress fracture can very easily turn into a full hip fracture if we're not careful with it. So we're looking for patients with inability to bear weight and acute pain. And then anything with nerve symptoms like radiculopathy, especially weakness in the distal extremities, those need urgent MRIs. So this is like a patient. So when I talk about acute hip pain, this is just like a healthy 20-year-old patient who all of a sudden has severe hip pain. And then they couldn't figure out why. She couldn't bear weight. And then it turned out she had this PVNS tumor in her hip joint. So we took this out arthroscopically for her, but really like severe symptoms like that will warrant further imaging. And then here's the proximal hamstring rupture where you see all this bruising. That gets an MRI ASAP. And this is what we see on that. So you see the hamstring insertion here totally off from the tuberosity and all this fluid in between. Nerve symptoms like radiculopathies, lumbar or cervical, these have high correlation with other injuries as well. But definitely anytime there's like numbness and tingling and especially weakness, that's really worrisome for nerve compression. And then stress fractures. So if they can't do like basically a simple hop, then and they're of these demographics where they could be at risk for getting a stress fracture with like female athletic triad and overuse injuries, then we definitely get those MRIs ASAP. And this is what that looks like, where you can have all that signal on the underside of the femoral head neck junction, and then we put them on crutches right away for that. Now, I'll also add one thing about post-op imaging. So you're seeing patients, they had surgery, and they're saying, "Oh, I'm still having pain. It's been 3 days since my surgery. Why is my shoulder still hurting? I want another MRI right away." So you'll basically want to counsel those patients a little bit about waiting, because of course, post-surgical pain can linger for a while. You're not going to be better right away. And also imaging postoperatively is just not very accurate early on, because there's so much fluid, there's so much stuff changing on a molecular level that early postoperative MRIs are not helpful for us or for the patient. Because when you get the MRI and we can't tell what it is, the radiology report is going to be all over the place, and it's just going to say all these words that freak out the patient. So I tend to hold off on postoperative imaging unless there's some kind of acute new event where they're doing fine and then something happened, they fell or they slipped or something dropped and they reached out too far and then it started hurting after that. When there's a new event, then of course we want to image it. But if there's no trauma or anything and it's just kind of slowly healing, then we just watch them, give them some time. So if there's not like a change in their physical exam, or if you're working with them on their cuff and they're progressing on their range of motion, all of a sudden they're back to like week 1, then we worry about that. And of course, signs of infection like wound problems. But if if it's none of those acute red flags, then we usually tend to wait at least 6 months for post-op imaging, because within that first 6 months, there's just too much abnormal, like just post-surgical changes and remodeling for us to interpret it. So for example, this is a patient I did a proximal hamstring on. She was she still had pain at 3 months. And I just, eventually gave in and got an MRI for her. And it looks kind of weird. So here's the tuberosity, here's the tendon. It looks like it might be close by, but maybe it's not fully healed. There's a little bit of artifact from the sutures, but it looks like there's some space between the black part, which is the end of the tendon, and the bone. But we just ended up watching that conservatively. 3 months later, we got another MRI. Hey, that looks like it's fully attached. So essentially all this white stuff, it's not fluid, it's just kind of like tissue that's changing and filling in. So that's why, when you wait 6 months, you can see a lot better what the soft tissue looks like versus just saying, oh, we need to go back in there right away at 3 months and re-repair this. And then when we just sat on it, it actually looks just fine. So doing imaging too early on is not necessarily helpful. All right, so wrapping up here, imaging summary. So patients are increasingly requesting advanced imaging, but it's important to start with, when we do imaging, it's important to start with plain x-rays. This is to rule out some of these really bad pathologies like tumors or arthritis and a kind of bony morphology. And then also there's so much insurance pushback. It's almost always necessary now to first get x-rays before they even allow us to get an MRI or anything else on top of that. But acute injuries, especially acute traumatic ones, get those patients referred to ortho urgently. Ortho has a lot better chance of getting in like an acute, basically urgent MRI approved than like the primary care doctor. And then post-surgery, unless there's any change in the condition, try to wait 6 months for any routine post-op healing imaging for that. Okay. Thank you. So this is my information. I also have an Instagram page that I just started recently, showing some cases on there as well. So feel free to give me a follow or a like sometime. Okay.
All right. And there is the live Dr. Zhang there. So excellent. How are you feeling, Dr. Zhang?
Yes, I feel fine, but my voice is just not quite there. So thanks everybody. Yeah, so sorry about my voice, but thanks for bearing with us. But happy to try to take some questions here.
Since you're a hip expert, we asked this earlier before, but when do you order a pelvic x-ray versus a hip x-ray?
Yeah, so the pelvic x-ray usually includes both hips and the whole pelvis. So we usually start with that because it's good to compare one side of the hip to the other one. But the specific hip x-rays, there's various views, like the side view of it. and then we'll usually order an AP pelvis, and then also like a lateral of the hip that's being investigated. So we'll kind of do both, actually.
Okay, so we have one question here. For shoulders and knees, if the patient is too claustrophobic to tolerate a regular MRI, is an open MRI worth it? Great question.
Yeah, so yeah, I left that one there because I was responding to another question right below it, where it also talked about spine MRIs. I think in general, open MRIs have very little utility. It's just such a low signal that you can't see very much at all. You might be able to pick up some bad red flag injuries, but most of the subtle things that we like to use an MRI for, you can't see with an open MRI. So I think the other question is if they have too much or their BMI is too high, what do you do? So then you can also try to do an ultrasound, especially if it's like a tendon injury, like the shoulder. Ultrasound works really great for that. Even like hamstring injuries, ultrasound has been pretty good for diagnosing those as well.
What about like meniscus tears and ACL? Can an open MRI pick that one up?
So you could probably get an ACL tear from an open MRI, but a meniscus tear, it's very hard to tell from an open MRI.
What imaging study is good for osteomyelitis?
That would be like one of those nuclear bone scans, because and or an MRI. So you could probably start with an MRI, which is easier to get because that'll show you if there's like fluid inside of the bone and how bad it looks. And then if you get like a bone scan or a nuclear bone scan where they tag like an isotope and then inject that, it'll go to the site where there's a lot of metabolic activity, which can diagnose osteomyelitis.
All right, so I'm checking the screens. This is maybe a last call for questions for Dr. Zhang, and I love the talk. Thanks so much. And let's see if anybody comes in with anything else.
I see one that says, should I worry about coverage for musculoskeletal MRI in ED? I'm not sure what they mean by coverage, like insurance coverage. It's at least at UCSF, it's very seldom they actually do a musculoskeletal MRI in the ED. Usually they'll do CT scans, but anything where they need an MRI, they kind of do have the patient come back as an outpatient.